they'll start doing some work around health equity, starting with provider diversity in their plans and access in their plans. So that'll be exciting to get that started. I talked to the Senate Bill 889 committee staff, Sarah Bartleman, and have a brief update. This is attachment 2. This is the VBP principles adopted by the committee and the attachment. And she gave me some notes. Essentially, Oregon has been invited to apply for a 2-year technical assistance program for states implementing cost growth targets. This is through the Patterson-Milbank Foundation.
Okay.
In attachment 2, the committee finalized those VBP principles that are attached. And OHA is having conversations with the Oregon Health Leadership Council about a potential partnership to convene signers for the VBP voluntary compact by the end of the year, and to support an implementation work group in 2021. More details to come on this. I believe Siobhan Martin is on that work group of the PEBB board. We'll get more information around that soon. A couple other things. The committee was in support of the recommendation to ask the Health Plan Quality Metrics Committee to identify a subset of their menu of measures that could be used to report on quality as part of the cost growth target program, and emphasize the importance of alignment with PEBB and OEBB and CCOs. That's good. Lastly, the committee was in support of both efforts to monitor for unintended consequences like access issues and workforce issues, and conducting analysis looking at variation in utilization and costs across populations. And that's all I have. We'll probably have her, Sarah Bartleman, come back at the next meeting. Things are really starting to pick up around the compact, and they're actually doing some work around accountability right now. How to hold, I guess, providers to the statewide cost growth target. What happens if they don't meet it? But more to come on that. Any questions?
Anything in particular you want to point out in here, Ali?
I think that was it.
Short and sweet.
Short and sweet.
Thank you.
Yep.
So, James, I guess you're up next with Lodestar Framework refresher.
Yes. I will get to those slides. I think. There we go. All right. The objective here is to pick up where we left off quite some time ago with the introduction to the idea of a reformed health offering for PEBB and OEBB that would sort of cut to the chase and sort of a vision quest for a future offering that would have a better member experience, would meet budget, have more quality related payment and better incentives. And this presentation, I think, was in November maybe, and then I can't quite remember, but it was in process when COVID hit.
Yeah.
So when that happened, it went sort of into the background, but we've been evolving the ideas, and so this is to bring them back to the forefront, make sure everybody remembers where we were and go a little bit farther, and then it has some suggestions at the end for what next. So to review, the idea was to have a complementary alternative to the current managed care plan offerings, meaning not a replacement, not a one-stop shopping, not a single program, but a sort of a PEBB and OEBB designed solution set that would meet some of the requirements of value-based purchasing, Senate Bill 889, and especially a global budget. So it was focused on improved payment methods, or sort of a skeleton by which the quality-related payments could coexist with a global budget adjustment, and hopefully with better incentives for sort of all parts of the system. The second branch really was a strong focus on advocacy-based model, so that the member had a more integrated, satisfying, and high-quality health experience. From a value-based purchasing standpoint, you'll all remember the healthcare LAN continuum. The idea is to sort of start back on the left with something that looks like, you know, a fee-for-service program, build in some foundational payments for infrastructure, but then leapfrog to the far reaches of the LAN continuum to a population-based global budget approach. There is the concept of fee-for-service payment, but it is not a fee-for-service program with the same volume incentives that we're trying to get rid of. So we'll say more about that as we go forward. We developed sort of a simple approach to try and communicate better about it. The 4 pillars. One was that advocacy-based member experience that I mentioned. 2, the payment technologies would be sort of rationalized and linked to Medicare. Not that it would be Medicare, not that it would be 200% of Medicare, but it would be Medicare componentry, and then sort of market-based percentages or policy-based percentages, or a combination of both. The third pillar was that over time, those payments would become more and more related to quality. And for conversation's sake, we are now building in the idea that it would be about plus or minus 7.5% in year 2 and plus or minus 15%, so that the goal would be to have 30% of payment to providers contingent on quality. Pillar 4 was simply that all payments would be marginally adjusted to meet the global budget, so that if inefficiencies are being squeezed out of the healthcare delivery system, you might see the global budget adjuster be 102%, meaning all the payments in the program would be a little bit higher because inefficiencies are being removed. Conversely, if the program was not meeting the budget, all the payments might be adjusted by 99 or 98 or some percent to ensure the global budget was met. The administrative framework that we're starting with, now this is all innovation because we are, after all, the Innovation Workgroup. The administrative structure that we're starting with is a 2-vendor idea. That one would be sort of the hard side with all of this fee schedule technology, and that there would be a vendor that delivered the network but used the payment policies of the 4 pillars, strong on data and quality calculations, and that would be sort of the administrative services vendor, probably not an insurance risk, probably not a managed care insurer concept, although a managed care insurer could offer these types of payment technologies without the insurance part of it. The second vendor, as we're envisioning it, is the member advocacy vendor that would work on the pillar 1. And we're going to talk more about all these pillars coming up. So then again, this is just one of those happy slides. Happier members, transparency and better incentives, quality and value baked in, strong systems so that we can know what's in there and adjust the equity in the systems of care, budget stability. The last couple slides are on the fact that this is sort of and has been sort of in the spirit of Senate Bill 889. And so this is just a little side by side that Senate 889 wants a cost target, wants statewide cost growth, and realigned incentives. I mean, we've been saying these words now for a good long time. It's legislated, and it is tried to be represented in the Lodestar development. So the Lodestar is intended to be sort of a prescriptive model designed by the PEBB and the OEBB to just cut to the Senate Bill 889 endgame. The background work we were doing, actually, I'll stop there just for a second, take a breath. Did I say anything that anyone wants to question or comment on before I go to a little demo of this conceptual framework?
Yeah, if we could back up to page 4, the 2-vendor approach. So is that proposed to integrate with, say, 3 carriers that are providing the insurance so they all have the same platform there? Or would each of those carriers providing some or all of those services be acceptable?
So I'm going to switch slides to answer your question back up to this one.
Okay.
In this land of value-based payment, people talk about a flexible approach or a prescriptive approach. And largely what OHA and PEBB and OEBB are doing to some degree with the current managed care insurers is a flexible approach. We're saying we'd like you to have 30% of payment in category 3B or better, or I just saw those fly by on Ali's attachment. So that's kind of saying you can do it how you like. We want 30% of alternative payment methods at a certain level of robustness by a certain year. The Lodestar idea is not to change that part of the flexible managed care entities trying to get to the same end game with a more flexible approach. It is more of a prescriptive approach, one way to do it, where the methods, this Medicare linking and the floating fee schedule as adjusted by a global budget adjuster, that's intended to be kind of the one that we build versus the one that we pay someone else or buy. So to the extent that these ideas resonate and the managed care vendors want to up their game on advocacy or site neutral payments or those kinds of things that we're talking about, that would be good. But the idea here is more that this would be the other side of the coin. There's the managed care plan flexible approach. There's this prescriptive Lodestar approach. Think like, more of a self-insured program or something, Jeff, where there would be super big emphasis on the advocacy member experience. And there'd be a super big emphasis on really strong payment and flexible payment with this Medicare linking, quality built in, and global budget adjuster. These 2 vendors could get together and have one big bid. It could be that one of our current vendors, who we know the names of, loves these ideas and wants to bid for the combination of a advocacy and network payment data vendor, but it is not intended to tell them what to do or have the current managed care offerings be replaced.
Wouldn't we be building specifications for services to be bid upon, so that they would bid as we have requested, as opposed to comparing offerings.
Who are they in your question?
Well, these vendors, whoever they may be, we would want them to propose based on our, I would presume, strict specifications.
Yes, I think that's, and we'll get to an idea for next steps, which is an RFI. We'll get to that a little bit later. But yes, the idea is that the design specs for the Lodestar framework would get clearly communicated, and we would solicit the market for solutions that match our requirements.
Okay. Thank you.
Okay, the next thing we did, I think is kind of fun, but I'm a little bit of a nerd. Because we didn't want to have a 50-page document that you read from the front to the end, we have built this conceptual framework that we presented last year to a greater level of specificity, and we did it in sort of an interactive way. So I'm going to stop sharing here. This is the link. I wish it were a little easier to remember because it's got a lot of different capitalization letters, but I will show you what happens when you click that link. I think I will. One moment. There it is. So I was going to talk you through, this is an interactive thing. It can be printed. It can be a big old PDF, but we thought it'd be fun to organize it in a way that people could explore the idea. And after this meeting or now, anyone can use that link to go and get more information. So I thought I'd go through a little bit about the conceptual framework to remind you, and a little bit about this packaging, and then end up discussing what next. So again, we already said it's a complementary alternative, not a replacement for the managed care offerings. It's a prescribed model framework that meets the intent of Senate Bill 889. And we've got it organized in kind of a way that you can click and follow your interests. I mentioned the 4 pillars. I may have gone over this enough that we don't need to hit them again, but they are described here. And I think it might be better to skip the summary and go to some more detail. That administrative structure was Jeff's question. We see this as, a pretty dynamic program where all this data and quality results are available to the member advocates, so the program sort of leans into a value-based, quality-related program where the member advocates know which providers are high quality or low cost, or which facilities are safer for surgeries, and that there's a strong integration of data. We didn't talk much about the advocacy-based member experience in our first go-round. And so I thought I would develop that more. And we've got a new member on our team, Cindy Ward, who helped with this section. But the advocacy idea is that there's a quiver of supports so that people essentially have the right help no matter where they are on this continuum of healthy, getting sick, getting treated, and getting back out. So we've got it arranged under these sections. And there's a quiver of supports. The idea is that the advocacy vendor would have a single point of contact. And the other idea is that technology is leveraged both for a member to be a self-service person who can find a provider, research their conditions, or for a person who really wants their hand to be held through every step. And at that point, the member advocacy team comes into play. This is all just ideas put into a concept to evoke feedback. You know, if this goes out as an RFI, we may find that the advocacy vendors who are bidding say, oh, there's a better way. You want to have 2 social workers, or, you know, something in the team. But we had this idea developed to start the conversation. The concept is it'd be an advocacy lead, a physician advisor, a social worker, a clinical support team member, and a behavioral health professional. And that the advocacy team provides one-stop shopping experience for the member and kind of provides all of the traditional managed care functions. There's more detail on what the advocacy lead does and the other members, but I don't think I'll go through all of that. I want to give you more of a feel than use all our time on that detail. Talked about the quiver of supports. I did want to say, maybe I'll use this picture. We do have the inclusion of social and other supportive services, so social determinants of health. We do have the understanding of the benefits and the out-of-pocket costs. And I know that because PEBB has a few benefit designs and OEBB has a few benefit designs, being able to speak to the member about how their decisions will impact and interrelate with their benefit designs is an important component. This idea of finding the quality providers and helping understand the medical conditions and the treatment options is hopefully, you know, this addresses the issue where if you go to the orthopedic surgeon, you need surgery, and if you go to the physical therapist, you need physical therapy. There's a hope that this advocate will help you understand the different options and make a good choice, and then help you find the quality provider. When we talk about things like expert medical opinions and centers of excellence, were executed brilliantly, most care would be finding a provider of excellence and would be subject to an expert medical opinion. I wanted to reiterate that the idea is that this advocacy vendor would have self-service tools like apps and websites and things for someone who wanted to go and investigate their conditions or treatments or providers themselves. It would have a modest level of support for people who want a little help, and it would have a very high support for folks who needed serious advice and help with more complex conditions, or just because they were overwhelmed.
So another question, James. Currently, my healthcare is tracked by 3 different electronic medical record systems. Only a couple of my providers can talk to each other. Then I've got the carrier. How do you envision this working where someone's not having to yet again repeat their salient treatment to get the advice? I mean, do they have access to the claims with the carriers? You know, it's as much as we've come a long way, it's still pretty fragmented.
Yeah. The idea is that this network data quality vendor is super strong. That data is well summarized for the benefit of the advocacy team. And although that these ideas are more formative and not fully developed, there's a goal that sort of hub or electronic data collection, electronic medical records might be available to the providers who participate in the Lodestar. And I don't want to get myself, I don't want to talk farther than the ideas have been developed. So I know that it is complex, but your example is exactly the kind of thing that this innovation work group, Lodestar plan design should address. And the thinking is that via the network data quality vendor, there would be an integration of electronic medical records or a standardization of electronic medical records, or a way that all the providers in this broad-based network would be able to see what's happening with their members.
Yeah. Well, I don't raise that as an objection. I mean, we have to start somewhere, but just as a challenge.
Yeah, I think it is a challenge. And I think it's an area of this idea that does need further work.
James, Rep Nose had a question. I'll just read it to you. Is this a service that PEBB and OEBB would contract with, not just an approach, but more of a pitch, ? Truly wondering. So when we talk about all 4 pillars, I mean, that's really the model, and would go in an all-encompassing kind of medical RFP potentially, or potentially with existing carriers. I guess that's partly what the RFI is for, but you know, maybe you can address that more in depth.
Can you just read the question again real quick?
Why don't I just jump in here? This is Representative Nose. Hi everyone. I'm sorry I haven't been in a while. This is very interesting, and I guess what I'm just wondering is, am I listening to a way that PEBB and OEBB could do a better job of getting control of costs, and here's the innovative approach that is one option? Or is this like a pitch, like, hey, this is what we think we could do, and we're willing to work with Providence and Moda and Kaiser and your other providers to sort of do these things to help you get your costs down? I can't tell if I'm listening to an idea or if I'm listening to someone who's trying to get the business.
Yeah, so it's not so much a pitch as an idea we'd like people to agree with.
Okay.
I
would the pitch. I just wasn't clear what we were doing.
Yeah, the method that we got here really was sitting down and starting with, wouldn't it be cool if? And wouldn't it be cool if you could call one number and they would be able to help you without forwarding you or losing you or not knowing what your dental benefit was or whatever? And wouldn't it be cool if the program design inherently met the global budget? And wouldn't it be cool if the system maintained robust data collection without being stupid fee-for-service? So we started with the wouldn't it be cool if, and then let our minds wander.
And Jane, just to add on here, this is Sean Parkman, and yeah, so this idea really has emerged from the Innovation Workgroup, and James, who's been speaking here, has been helping us lead a process with our consultants to really think through this process. James, it might be helpful just for a second to just kind of reintroduce yourself, because I think it's been a while and we were on hiatus for a little bit. And after that, I do have a follow-up question to that's related to Representative Nose's.
Okay, so on the reintroduction, I'm James, and I do work for Mercer on the government side, not on the employer side. And Jeff, partly, and others asked if I could be sort of an adjunct member of the Innovation Workgroup because I'm old and I've been dragged through a lot in the Northwest healthcare reform. So I kind of function as the translator from the work group to the 2 different consulting teams that represent PEBB and OEBB. And then on this project, I liked it enough that I got a little more involved. So I'm an actuary, and I've been, between Washington and Oregon, have done a fair bit of really, not yet brilliantly successful healthcare reform projects. We have been working on this for years. This idea of sort of a floating fee schedule change to provider incentives is not new, but it bubbled up again in the context of a value-based budget meeting, incentive changing, employer design value program.
Well, James, I must be in an important meeting because you're only the second actuary I've ever met in my lifetime. And I'm going to be 53 in December. So usually somebody in charge is telling me the actuary said this, and then I just have to accept it. So
yeah, they don't let us out much.
So, Sean, you had another comment, and then I have one after yours. Or
Yeah.
question.
Yeah. So James, can you go back way up to the top of this? The welcome, basically. I'm going to ask you to repeat something again, just to be sure that I'm getting it, which is it's a comment basically that it can coexist. Is that in this page?
Yeah, the complementary alternative to current managed care offerings.
Yeah. What does that mean? Like, what do we actually mean by that? How would this fit with current programs? Help me understand that.
Terminology can be dangerous, and so I don't want to send the wrong terminology-based information, but the things that this would not be, it would not be insured. So it would be either explicitly or over on the self-insured side. It would be a fee schedule, albeit quality related and value based, but it would be a fee schedule, not a capitated PMPM payment to a insurance vendor managed care plan. On the PEBB side, you could almost think of it as reimagining the statewide. So the idea would be a broad provider network with lots of choice, with relatively good access to providers around the state, self-insured underpinnings, and some fee-for-service kind of concepts. But I have to be careful every time I say fee-for-service because I don't mean full fee-for-service payment with full volume incentives. I mean quality-linked, global budget adjusted, 70% fee-for-service, 30% quality, based on the Medicare links. So it's a little bit subtle, but the idea, years ago I worked in Washington and we had a uniform medical plan, which was like a self-insured PPO. And then we had the managed care offerings that were more fully insured HMOs. And it was helpful at that time to use them as a foil for each other or a comparison for each other. Mm-hmm. And we could use tools like risk adjustment to see whether the managed care plans with higher administrative loads were reducing the cost of care or improving the quality more or less than the less managed or less expensively managed, self-insured, more PPO style plan. So this is sort of an idea to have a state-designed prescriptive model that's a value-based solution, and then continue to have the flexible solutions, either a narrower network or a different, managed care organizations model. This one is 70% Medicare linked fee schedule, 30% quality, and a global budget adjuster. The Modem might say, well, we're going to do episode-based payment and subcapitated specialists and whatever. So they would have flexibility to do network contracts and payment levels and things that they wanted, as they do now. Providence would do what they want within the flexible value-based purchasing goals, like the 30% by 2023 or whatever. And the Lodestar would be more the PEBB and OEB's standard fallback, broad network, prescriptive solution to accomplish the same Senate 889 kind of goals, but in a proactive, prospective decision fashion.
So my question is, the member advocacy vendor, the priority is for quality of care or for saving money?
Member experience, quality of care.
Okay.
The saving money really comes through on the global budget, pillar 4. And it's not so much saving money as just managing your budget. Now, there's a good chance that if this advocacy thing is working well, the advocate will help the person with lower back pain get rid of it without requiring surgery. There's a good chance that good care could cost less, but there's a chance that some good care could cost more. But the focus of this, they would need to know the cost efficiency and the quality of the providers that they're helping the members to get to. But I don't think that that would be in their performance contract for the member advocacy. It would be more purely make the experience and the outcomes, the referrals, the satisfaction greater.
I think you could add virtual care, accessing the virtual care. You could add accessing diverse providers. They had special needs.
Yeah, we do have thinking that with today's world, because this is a pie in the sky future vision, there's the opportunity for us to amplify or improve the requirements for the vendors with cultural awareness, social determinants, and health inequities.
Okay, but just to follow up on this, there are limits to how much we can. I mean, these are some pretty fundamental changes in the structure of what we're, wanting to have in contract. And there's only so much that we can alter our current contracts before we kind of have to go to a new RFP process,
Absolutely.
So are we presuming, like when we're talking about like augment or alternative or whatever, is there a presumption? Oh, implement. Okay, you're going to get there. And then while you're looking into the future, my upcoming question, which perhaps you will address as you're going forward here, is in addition to what I just said, is also a little more information about how that, what is it called, the advocacy part of it, that vendor, how they would be compensated. Like, what are they? They don't get more money if they funnel people to more expensive procedures, which is kind of the way the system is set up now, right? Cynically, I mean, frankly. But so how would they be compensated? Like, what would their incentives be? That vendor. So those are my questions as you're moving forward here.
Yeah. Let me answer your first one, and then I might ask Cindy Ward to introduce herself and jump in on the member advocacy vendor and sort of payment terms. This is the idea and the conceptual framework of an idea for one instance of a Senate Bill 889 kind of future. And it is definitely innovative because we're the Innovation Workgroup. We kind of think on the consulting teams that an RFI makes sense for three reasons. One, these are some big new ideas, and it'd be good to see if current mainstream or alternative vendors come out of the woodwork to say, yes, we can make your dreams come true. So we thought that between now and January, between now and the end of the year, we could suggest, if the boards and the two boards and the work group members like this idea, that an RFI would go out broadly to the market for potential vendors. We also thought that that RFI process would sort of be a statement of goals or direction or something, and that you might get very interesting feedback. Your RFI could be open for a request for information from other stakeholders in the state. So it could be a little bit of a first test of the reaction to the important people who be part of this system. And then third, when you combine those two things, it could be a bit of a feasibility, step that could feed into should we move forward or not early in 2021. So between feedback from our own organ provider and interested party community, between what we hear from possible vendors, a level of interest, we would maybe know whether phase 2 and phase 3 look like a go or a no-go. On your second question, Cindy, I think you're on, and although the real details of the exact payment methods for the member advocacy vendor we have not yet spec'd, I'm sure you have thoughts.
Yes, this is Cindy. Can you hear me okay?
Yes.
So when we looked at wouldn't it be cool if model, we really tried to throw everything into the member advocate model. But at the same time, there are some vendors currently in the market that do at least a lot of the components that we've built in here. So it was really looking at what the market could bring to bear, who's doing something that is really innovative already, and can we stretch that a little further? The way that the payment model works for them today, these types of vendors typically are hired by employer insurers to manage cost. At the end of the day, it is about a member experience, but the value proposition to providing this really is that there's a lot of inefficiency in the healthcare system, and a lot of these the quivers in a member advocacy toolkit really do, at the end of the day, if you're truly driving towards value, because there's a lot of opportunity for savings in the healthcare system, savings should be achieved. So they really put themselves out there as reducing pharmacy costs, reducing costs for members with multiple chronic conditions, and overall medical costs, with probably, redirecting quality care to provider network providers that have high value. So they're constantly monitoring the provider network, evaluating the provider network for quality, and cost obviously being a component of that, but not the only component. As James said, there could be a high quality provider that does the best hip surgeries in the state, and they cost a little bit more, but their outcomes ultimately are better. So they have multiple ways of both making the members experience more of a concierge type experience, with the purpose of helping someone navigate a very complex health system where they may not know who the best physician is to go and get that carpal tunnel surgery. And the best physician may also be the least expensive in that market. So there are levers that they are pulling. Obviously, part of their business proposition is that they are saving money at the same time while making a member experience both positive and helping them navigate the healthcare system much more effectively. To your direct question on the funding mechanism within the Lodestar, I think that's one of the areas that we haven't thought through. We would welcome some thoughts on how to do that, but ultimately, if the member advocacy model works as intended, there should be some savings realized, especially for members who are right now having very inefficient costs within the system.
This is Dana. I just want to jump in on this conversation. Really helpful, Cindy and James. I think you mentioned this too, but right before this last piece was going to come up, I just wanted to hone back in on some of the comments made about this advocacy member experience model, how it could be organized such that it addresses health equity, access to broader and more diverse workforce, for example, things that certainly the PEBB board has been talking about in more detail recently. And I just want to come back to kind of the points already made that we really set out on this effort focused on the financial opportunity here, right? We were focused on our potential savings, our targets we need to meet, and that's a different framework to engage in this conversation. I am not saying that they are mutually exclusive, but if we're looking at an RFI and we're thinking about centering health equity and the work we're doing ahead, we have to recognize both the structural racism, both in the market and our healthcare system, and the implicit bias of decision-making, either probably clearly through healthcare providers, perhaps through an advocacy member experience. And I think those are critical. And so I think it's easy to say the notion of, we can capture those intents within a member advocacy approach, but we weren't engaging in this approach, thinking about it from a member-centric, health equity-centric focus. And if we're going to do so effectively, we really need to have PEBB members, OEBB members engaged in the process, helping to frame out what the RFI looks like so that it actually gets to the outcome we're trying to get to, because they're not things you can just add on the back end while really the goal is financial savings. So I think that there's a process here with this timeline and an approach that we could make sure that the development of this really has the priorities at the center of it, if that's what we're truly trying to get. So some comments.
Yeah, I think that's great, Dana. And we've had similar conversations about this being a time where, since it is new and formative, there's time to try to build the best possible mousetrap. We've had good conversations about, some of the challenges with different health disparities, like environmental ones, and that the health advocate could know if there's a Superfund site around the corner from the member they're working with, or that kind of, population health sort of merging into this advocacy model. But it's a great idea to build it out with some broader participation.
Yeah, we could run this, Dana, by the PEBB member advisory committee, and we do have a member advisory committee within OEBB as well, and get them involved at the right time. If it's before the RFI, then we could certainly do that.
I think that pathway will be helpful.
Yeah, I do too.
These have been good conversations. I'm not sure. It's 2:24, Ollie. I think there's another 15 or 20 minutes for this agenda item. Is there any special direction you'd like us to go at this time? We have like little examples about how the we could do a little reminder on what we learned on our Medicare linked, our percent of Medicare study from last year. We could talk a little bit about the how the global budget concept would be implemented. I'm not sure what makes the most sense.
Well,
This is a work in progress, like under FAQs and area for refinement. We've got some, but you know, it's a little bit of a parking lot, and you know, we'll add based on this discussion. So what would you recommend, or Jeff or Sean? Is there an area that you'd like to hear us talk more about?
well, before we run out of time, I guess I would like to talk about the next steps, not starting in January, but before that. So I like, so there's a lot here. As you know, I throughout this process, I mean, I think it's a good idea. I like how this is laid out. I think Dana's comments here are important to incorporate. So there's that. That being said, this slide right here has the RFI released in January. So if we were to proceed, which I just for the record believe we should, what would need to happen? Because I mean, there's a lot of detail, but I assume it would still take some work in order to actually get this into the format of an RFI. And you would need to know that the boards are supportive of it before that point. And as you can tell from the way, you know, like we've been along with you this whole ride mostly, and we still have a bunch of questions, right? So you can imagine going to the boards and just like what you just said, you know, oh, we did this analysis last summer. We didn't even get to that, you know. So this could take some time to explain. It's a big thing. So I'm just curious, Ali, James, and well, everyone, like what would need to happen by January with the boards? How can we describe this to where it makes sense? I mean, it takes a few minutes to get your head around it. At first, I think it kind of strikes you as like, is this different? You know, and then you more start digging and you're like, oh, this is very different. So anyway, what are your thoughts?
Before you answer Sean's question, can I ask you, James and Wendy, do you have any other clients that are pursuing this at this time? You don't need to name them, but
No, this is a one-off OEBB PEBB idea at this point.
okay.
I would say that there are components of this idea that are being considered, and every once in a while, I think this is a little bit like the TRICARE program, or
Sure.
what the TRICARE program could evolve to, but that's arcane.
So in developing an RFI, you'd be starting from scratch.
Sort of. I think we would be looking for, you know, some other RFIs that had to do with an advocacy concept, and we'd have some work to do. I think our thinking is that the RFI would clearly communicate where we want to get in our early ideas in this conceptual framework, but we would leave the opening for friendly amendment in the RFI responses. I don't know, Cindy or any of the other consultants on the call, if I answered that right. But I see this as, you know, the concept about the floating adjuster to meet the budget and stuff, that's pretty far out there, Jeff.
So to Sean's question, next steps. Could you?
I don't think an RFI really isn't anything like an RFP. I mean, it's more coming up with a list of questions to really understand what's out there, you know, before we can really move much farther. But it's asking the right questions, I guess. You know, we can go and present this to PMAC and talk to them about it, and talk about our focus on health equity, which, you know, is something that they've been talking a lot about, and then talk to the boards in January. You know, still conceptually, This is bringing in all kind of the goals and the legal directives, the 3.4%, the BBP, the 200% hospital cap, you know, move to virtual care, kind of bringing everything together, I guess. But we don't really understand what's out there yet.
Yeah, that does make sense, and I do think there's some cleverness to consider around crafting a good RFI, because I think the default for the market is to try to answer the questions with basically repackaging what they're already doing, because change is hard. And we do not want that response. Like, what a waste of time. So we want this framed in such a way that it's so clear that there's really no way people have, you know, they have to innovate or they shouldn't respond, basically. So that may take some time to put that together well. But I'm hearing you say, Ali, that it might be okay to have that discussion with the board in January. To launch the RFI perhaps in February. I don't know. That's a pretty fast turnaround, it seems to me. I don't know, for an RFI design. I could be wrong. I don't know. I haven't done one.
Oh, we should ask James and Wendy whether that's too fast or are they ready to go sooner than that?
So there would be a process to develop the RFI, and I think that we might not have envisioned all the authorization steps and the time constraints for those. I think in our original thought, we'd take sort of the rest of the year to get it ready and release it in January. And it shouldn't be a ton of work, but if we don't start work until both boards have said go, you know, we might need to push the timeline back a little bit. You know, these ideas are ready to refresh with the boards. Both boards heard a little bit about the Lodestar. I can't remember if it was the end of the year or the very beginning of 2020. But it was, again, relatively quick and not nearly as deep. So I think we could respond to whatever makes sense from an administrative perspective, but a month would be a push. Probably, you know, a couple months just to get it reviewed and make sure the right people participate, you know, that would want to do a good job with it.
So it seems like you would need to go to the PMAC committee and the OEB equivalent like real soon to get that ball rolling. And then it seems like we would want to bring it to the boards before January. I would maybe. I mean, we're still planning on having a December meeting. Yes.
Yes.
So maybe, like, I know that's making it tight still, James, for you, but it seems like later than December.
There's a chance that some relatively light duty work could continue waiting for these meetings or sessions to happen.
Yeah.
And that we could try to have, you know, I think that it's this conceptual framework that needs buying into, not the final RFP or RFI language. But I think we could continue, you know, keeping alive like we did during COVID. We could continue to evolve some things while we get to present the framework. And there's nothing completely written in stone about January or February or March, but we did want we want to be clear that the RFP will be relatively heavy. And we wanted to have plenty of time for implementation. And it's not really on here, but sort of across this whole chart is, you know, design and develop, you know, finalize, design and develop. because if we're going to be the OEB PEB masters of a state design program, there are details, many that will need to be thought through. You know, we need to write up issue papers about what flavor of DRG groupers to use. It'll be, you know, it's exciting and fun to think about getting to the future, but there would be a lot of heavy lifting in 2020, late 2021 and 2022.
James, I see on this slide in front of us that it talks about phase, you know, implementation and phase in. Is there given some thought for an incremental approach to achieving the goals, you know, or a step approach?
You know, the phase in slide is a little bit different concept. It's not sort of getting started on a phase in basis, but it's phasing in the changes to status quo. So like if we started with market-based Medicare conversions, like, you know, durable medical equipment is 130% of Medicare and specialists are 180. If somehow through laborious stakeholder and other processes, those things are going to change, any kind of equity-based changes where there are winners and losers could be phased in over time. I think that's what we're saying here. Now, in terms of phasing in the conceptual framework over time, I guess we have a little bit of an idea on that too, Jeff, which is you could start assuming good quality, and then in the first year, like this plus or minus 7.5, plus or minus 15, you know, you can't just start taking money out of the system for low quality. You need to start with a fully funded system and give time for folks to react to changes that might be upcoming. So I don't see a good option. I think the fundamental structure, this is so different, those linked quality related, whatever fee schedules, we can have the quality phase in, we can have the global budget phase in, but that first step where you get a bunch of Medicare linked payment, that's a pretty big technical lift, and it sort of, I feel like it kind of needs to be done at once.
Yeah, and even the advocacy is going to have to find ways to integrate with multiple systems, and just because we ask for it doesn't mean we get it. So there are challenges there.
Right.
Well, nothing ventured, nothing gained, right?
Yeah, you know, in the world of consulting, it's unusual to get questions like this. What would you do? How can we innovate?
Mm-hmm.
And so we're enjoying this process of the wouldn't it be cool if, and there's no doubt that this is a sea change of an idea, and that it will need to be done well to be accepted by all the people it would impact. And, you know, an early concern is, won't providers hate this? Well, I think part of the goal is to make it so providers don't hate it, that the payment is revenue neutral at first and equitable going forward, that some of the variation gets taken out, but some other things become positive. So it's a big fat idea. There's no doubt about it.
Yeah.
So moving forward, it makes sense to me that it's a good idea to present to the various subcommittees within OEB and PEB, so CL within OEB, and then I don't remember what's called PPEP or whatever in PEB, probably next month, and then a presentation to the full board in December.
Agreed.
Okay. You need anything more, Ollie?
No, I mean, you know, I don't want to hijack PMAC's work plan, so we'll need to check in with them, but I think they would be more than happy to participate. And I think it's just bringing the right questions around health equity, you know, disparities or to them that they can discuss, you know, as well as the boards, and not just bring this to them and expect them to come up with specific questions for the RFI. We'll have to start developing those.
Yeah, that's right. I mean, health equity, I think, needs to be addressed. And then we're going to, you know, we have to have the conversation about like network size, network access. I mean, that's going to be the questions that we're going to get from members. So we may as well have an answer for that now. So that, yeah, but those feel like the right questions to address, you know?
So what is the likelihood if we go to our providers and say, we want a paradigm shift structure, and they say, no, we're not willing to do that? What is the likelihood that we have a hard time finding a vendor that's willing to operate within a substantively different structure?
Then we don't do it, I think.
Well, therein lies the incremental implementation. Is you got to heat the water up more slowly.
I do think that you're a big couple of programs. I do think that there are aspects of this that could be seen positively by providers. I do think that there are things that could be built in to make their lives less annoying or better in other ways. From a vendor standpoint, I think that there's a big focus on creativity and innovation now. My own employee benefits this year just came with the word advocate, which I thought was interesting. So some of this stuff is mainstream thinking, the value-based purchasing, the quality-related payment, the member advocacy. These are all components of things that are trending. The packaging of them is different. The guaranteed budget is different. And I guess I think that the RFI process is one where we will see the level of interest and optimism and creativity and willingness to innovate. So I do think that those are the exact questions. What can the vendors do? What will the community of providers and interested parties say? And I don't think we should go out too strong too soon, but I do think that, you know, as these ideas get built out and this online thing, you know, might need a little more tweaking, but people could go and react to this. It could be part of the RFI. It could be to go review the conceptual framework on the internet. But I think the question of whether this fundamental change could be supported is good. Now back to that Washington example I gave of the Uniform Medical Plan. It was a very different time and the context was very different. But they had a big fat public process where they developed fee schedules for hospital, inpatient, outpatient, physician. It was all completely transparent. It didn't have this global budget adjuster, but it did have sort of obvious conversion factors and then different ones for Medicaid and for commercial and for labor and industries. And that did work. And they had a great big network with most all providers in the state. And they didn't have to do a lot of carrot or stick, I don't think, on that program.
Yeah, and plus, I think that I mean, it's a good question. Like, what if no one bites? But as we started out this whole meeting, we, you know, this is basically one attempt to realize the goals of 889, right?
Yeah, exactly.
And so if with the work that Jeremy Van Hay and others are trying to do is to get the market to voluntarily embrace value-based payments, and then we try this to embrace value-based payments in a specific way, and like no one gets anyone to bite, and in the market's just like no, and they take their toys and they go home, then maybe that's a signal that will be a good piece of information. At that point, maybe our legislative partners are like, oh, well, interesting. You know, in order to continue on the path of value-based payments, that may require legislation, you know, but it would be a good data point for the powers that be to just like, if no one responds, then it's like, okie doke. That is where our market is. They are not going to do value-based payments unless someone drags them into it.
And you know, Sean, you made me think there, given the 889 and the 3.4% statewide goal, where they're still thinking how to enforce. One thing that's good about this idea of the budget adjuster and the 3.4, it's about as broad and modest of a way to meet a statewide budget as you could have. It's a small haircut for everybody. It's not disproportionately hitting any insurer or provider type. And to the extent that there's going to be a 3.4% future, it's not a bad way to do it.
I mean, this is Dana. I will just add on to your points, Sean. I mean, I am excited for us to carry this conversation forward with the full PEBB board and with Jeremy and with the 889 work. That's really an opportunity for a strong cross-market proposition and effort. You know, we, through our CCO contracts, are requiring CCOs to hit roadmap targets. We've discussed those as PEBB, and we have the opportunity through our contractual relationship with CCOs to get there. Likewise, I would expect that PEBB and OEBB have, in a different framework than Lodestar, the opportunity to do that with our future contracting. So I think there's not just a one and done with 889, I think, or even Lodestar. I think we have other tools that we just need to keep our eyes open on as we move forward. And see where the 889 work and how we can dovetail off that as well.
Yeah, that's a good point. I guess, yep. I guess I would, this would be another signal, I guess, to the market of like, this is happening, you know? So you can be part of the design or not, but.
I think you're right, yeah. I'll take it.
Okay.
All right, well, we are on schedule with the agenda then. And I think it calls for, 1 second.
Short break.
Short break.
So we
Jeff,
are
do you wanna do
5 minutes.
okay.
Anybody need more than that?
Nope, that sounds good.
Okay, we'll be back at 5 minutes to 3.
Okay.
Hey, James, this is Brad. I don't know if you're there. I assume you're going to be doing the driving for the Centers of Excellence deck.
I'm happy to do that if you just say next slide. And if you'd like
Perfect.
to do it, I could let you share, but I've got it queued up.
That sounds great.
Okay.
We could probably get it figured out for me, but it may take 5 or 10 minutes or an hour.
Yeah, I am sharing it as a PDF, but it looks,
Okay.
your slides are a good size and shape. It looks better than some of the other documents.
Oh, perfect.
Good.
Perfect.
All right. Well, we're ready to get going again.
Okay. Well, this is Brad Lawson, and I've got Dr. Lewis Dickey with me, and we are going to talk a little bit about centers of excellence. Similar to Lodestar, although not quite as fun and interesting as Lodestar. We were kind of going down this path at the beginning of the year before the pandemic hit, and we have had a long hiatus. Thought it would be a good idea to kind of go over the centers of excellence a little bit, give some background on how we got here, what the opportunities are, both from a more general marketplace and kind of more specific to the PEB and OEB plans, and then kind of give a broad overview of definition, framework, selection criteria, best practices, and then specific considerations, and then take a look at the project timeline and next steps. So, James, if you want to advance, I think I've just covered our contents. And we can kind of go into, I think, what's labeled as slide 3 on the screen there. And so recall that starting way back in March of 2019, we did a very deep dive cost drivers analysis for the combined OEB and PEB plans. And we followed up a couple different times throughout the year, and we sort of ended in September with looking at some really detailed focus on spine, back, hip, and knees. And I think we had some cancer stuff thrown in there too. And then finally in December of last year, which is, goodness sakes, 10 months ago already, the IWG decided that to have both OEBs and PEBS carriers respond with an RFI regarding their current COE capabilities, and kind of put that or incorporate that into the renewal process for the next year's renewal cycle. And that's, of course, 2021 for PEB and 2020-2021 for OEB. And we were looking at had decided to look at a potential pilot for just the musculoskeletal spine, back, hip, and knee conditions. So that is kind of where we're at today. We're going to do a little bit of a refresher. If we want to slip to slide 4, this slide really shows just some general market statistics, that have been driving employers and plans to really focus on musculoskeletal over the past several years. They range from, frequency and prevalence, appropriateness of care. We see a lot of cost variations, knowing that some of that's mitigated through our 1067 hospital cap, and outcomes as well. So we've got a lot of different statistics that suggest not only from a planned volume, but from some appropriateness of care and efficacy things that really that suggest looking at this. So if we turn to slide 5, we going to focus a little bit more in on some specific OEB-PEB opportunities. It's kind of a rule of thumb is sort of up to 30% of our back, spine, hip, and knee surgeries are believed to be medically unnecessary. And if we take a look and kind of at that table down there in the first set of tables, and if we combine all of those surgical expenses together, we get about $63 million of spend and almost $1,300 member impacts for these 4 different surgery types. And when we think about the 30%, we can sort of quantify those into anywhere between $8 and $10 million for each of OEB and PEB of potential services that could be avoided with equally good outcomes. So in addition to our dollars, we can also kind of take a look at the quality metrics that we did a very deep dive, again, mid last year on quality for the combined plans. And if we just do some very high level summarization, I don't know if you guys recall, but we did very, very detailed look by hospital and all kinds of stuff. But in general, when we summarize all of those conditions together, we have almost a third of our procedures that are being done at facilities that have a less than 75% quality score. And so there's some opportunity there to shift the rest of those third back into high quality. And in fact, shift some of those that are between the 75th and 90th percentiles into facilities that are at the very top end of the quality scale. So finally, looking kind of at the table in the lower left-hand corner, we thought it just would be interesting to take a look at sort of some of the top hospitals that are performing these procedures and see whether or not they were subject to the hospital reimbursement cap, our 1067, 200% of Medicare. And in general, almost all of them are, with the exception of the St. Charles Health System in Redmond. Note that the Bend facility is in fact subject to that. So that's kind of the importance of looking at that is when we start thinking about the variability in cost, we know that some of that variation is going to be mitigated through 1067, although not the non-facility costs. So some of the other charges that we have, such as the surgical and professional pieces in there. All right, any questions on slide 5 before we move on? All right. So I'll turn it over to Lewis, who's going to walk us through, just some of the general COE background and the frameworks and such.
Yeah, thanks, Brad. And just to echo the earlier comments, I mean, the original charge by IWG was for us to look at your cost drivers, identify the opportunities, and then do some drill down. And of no surprise, MSK was one of the top drivers, and that's consistent with what we see across pretty much all clients. And when we looked at the opportunities, it's important, and we are talking about centers of excellence today, but just to go back as a reminder, we did look at the continuum of opportunities to look at MSK and what other solutions could be there, what solutions were in place, starting with prevention, which is where a member's not really showing symptoms, but what can we do to keep them from having MSK problems, whether it's weight loss, ergonomics, exercise. And certainly OEB and PEBB currently have some programs and a variety of programs that focus at these opportunities on prevention. Then moving within the steerage and decision support, again, the member has a MSK condition. How do we make sure they get to the right provider at the right cost and get the right care? And so again, we've got a variety of opportunities listed here around digital PT, treatment decision support, steerage. Some of those are currently in place. Some of those was part of our discussion that we had, which seems like forever ago, but it was about a year or so ago, around expert medical opinion and that opportunity. And also when we had some discussion with the MODA 360 earlier in the year about how that could potentially play into some of the steerage and treatment decision support. And then finally, which is what we're really going to go into a lot more detail today, is the bucket around supporting members that do need to have surgery. And again, looking at how do we get the best quality, how do we get the best outcome, how do we make sure we get the most value for the cost that you're going to pay, which has led us to the discussion on the centers of excellence. So next slide. And just as an overview, when we look at centers of excellence, it really is contracting our steerage to a specific hospital or a specific group of providers for a particular surgical procedure, which for today's conversation is back or joint surgery. So when you look at a designated facility, obviously they have to be specialized in that target procedure. We do want to look at higher volume, because that's very consistent with previous leapfrog type initiatives, that the more you do, the better you are, get better quality, lower mortality. And then can we look at things around protection on the reimbursement and moving away from the fee for service with certainly consistent with some of our prior discussion around value-based, bundle payments, warranties, other types of things so that there's some price protections. So when we look at the value of Center of Excellence, we talk about better outcomes at a lower cost. We get the outcomes because of getting the high quality providers that do more. And then we get savings through preferred pricing and improved quality and fewer adverse events, side effects, and complications. So next slide. So, and some of this we've talked about in the past, but just to revisit, how do you really determine what a Center of Excellence is or who should be a Center of Excellence? Again, these are pretty consistent criteria that are used by all the vendors, whether it's the health plans or the ones listed below, that you do want to make sure that they do a certain minimum volume of the procedures before you even consider them, and that makes sure there's sufficient cases to do the quality ranking. Then you look at the quality scores, look at cost efficiency, and this is usually on some sort of an episode of care grouper. I think it gets to one of the earlier comments that James made, that a particular surgeon or facility might have a higher cost for the particular surgery. But when you look at the total cost in terms of how they manage the total episode of care through reduced complications, more efficient uses of resources, they're lower. And so that's really the goal, is get the overall cost lower. And then finally, they have to be willing to contract, and you want to look at access. So we've talked about how do you get there and what are the options for you to go down the road of a Center of Excellence. Certainly the health plan is a way to go. As part of Brad's earlier comment, we did the RFI a year plus ago. MOTA doesn't currently have Centers of Excellence, but they've certainly expressed a willingness to do that. Kaiser has their approach, and Providence has their approach to Centers of Excellence. Another option is, and some clients pursue, having a third-party specialty vendor. And so this is all they do, is they develop quality networks, they develop Centers of Excellence, typically around surgical procedures. And we've listed 3 of the more common ones that are there, that are in the marketplace, with Bridge Health, Surgery Plus, and Carum Health. And then there's also some clients that go down the road of doing a direct contract. So they may approach Oregon State or Providence or some provider that they know has high quality and do a direct contract with them. And we've listed some of these across the country that are known for quality, like Cleveland Clinic for our cardiac, and Virginia Mason, and MD Anderson for cancer. Can we go to the next slide? So, what would be the process if we were going to do some sort of an RFI, assuming you were building this from scratch, or maybe looking at the third party doing it for you? So obviously they have to submit and complete a request for information. They have to meet the eligibility requirements. Some of these are very simple things like accreditation, participation in safety and quality programs, documented protocols, and then they would be additional program requirements relating to joint replacement and spine surgery. We've talked about the cost efficiency component, which again would be based on a episode type approach versus just the cost of the procedure. And then this also has to be balanced against the network access, because you want to make sure that members aren't having to travel a disproportionate distance. And so there is some balancing based on the access, and then looking at staffing and protocol and other sorts of reporting requirements, and we saw this, quite frankly, last year when we were looking at some of the detail on the cancer, that there was a big discrepancy in quality between the providers. So if you choose a facility and their best performing providers leave for whatever reason, then we would want to know that in case that would warrant making some sort of adjustment of who you're working with. And then we'll go to the next slide, and really think about what are the best practices when you look at a center of excellence. So there would be a pre-screening, and this can initially be like a chart review where the provider at the center of excellence would look at the prior treatment. They would look at the care, in particular conservative care. They would look at their overall health to make sure that they are fit for the procedure. And quite frankly, this part can also be where they would make a decision that the member really didn't need the surgery, which picks up on some of the earlier comments about the higher percentage of especially spine surgeries that really aren't necessary and members don't complete sufficient conservative care. So there is that avoided surgery component that you would see with the centers of excellence. There is more of a shared decision making, so it's not the physician saying, hey, you need surgery. It would be, let's talk about the options. There's different ways to maybe do the surgery. You would have a dedicated team of professionals. We've already talked a lot about the positive clinical, financial, and member experience outcomes. Obviously, as part of the quality would be the adherence to evidence-based clinical guidelines. So this could be certain care pathways associated with a hip surgery or knee surgery, so that certain things happen at the right time, so that if they are supposed to get a particular medication or anticoagulant or dose or something, they would get that. You definitely want to make sure there's good connection and follow up with the member's primary care physician, reporting not only to you, but also that they're participating in some sort of a statewide or national database for reporting. We also push for warranty so that there would be some period of time after the procedure that if the member encompasses what could have been perceived as an adverse outcome related to the surgery, that any of the care associated with that would be borne by the facility and not be additional cost to OEBB or PEBB. And in an ideal format, we would look at a bundled payment approach so that, again, you're getting away from the fee-for-service model. So be glad to answer any other questions. Again, this was just getting through the information. A lot of this we had reviewed in the past, but again, since it's been such a long time, wanted to revisit that as we talk about this topic. And I know we're ready to move to slide 11 with Brad, but again, we've covered a lot of information. Definitely any questions that this is raised or concerns or anything, we'd be glad to have that discussion.
All right, get myself off mute there.
Well,
all right.
What about the applicability in a state like Oregon where the dispersion of hospitals exist? What are some of the, I think we've listened to some of the benefits, but what are some of the challenges?
Yeah, great question, Jeff. And I think that gets to balancing the access when we look at a center of excellence. I mean, I don't think it would work if you had one facility that's maybe in Portland, like Oregon State, for example. And so you're going to have some flexibility so that you would have an east side state option so that people aren't having to drive over the Cascades to get over to Portland. The other part of that is typically with a center of excellence, clients would offer a travel and lodging if the member does have to travel over a certain distance. That can be varied. The more common distances are between 50 to 100 miles so that it offsets that cost. It also would include the cost of a companion, whether it's a spouse or whomever, to go with them. So there would be some other components to that, because you are, as you go down this, limiting options of where members could go. And for a state of Oregon, you're probably looking at, I don't want to be prescriptive, but it could be 2, 3, maybe 4 facilities that you would do this. The other thing is, and we've seen this across MSK, that a facility could be great or good for spine, but not for joint replacement. So it is very possible that you could have a facility that's a center of excellence for spine, but not joint, and they would go to someplace else for that. So there would be the communication requirements. making sure that the health plan or member services or advocacy service is aware of these other benefits, travel and lodging, aware of who the facilities are, have a way that if they're seeing a physician and they need surgery, that there's timely conversation with the member to make sure they're aware of the benefit or that there are centers of excellence. The other part would be, what sort of decision would OEB and PEB make around steerage? Are you going to have a tiered network so that, for example, your highest tier centers of excellence would have the lowest cost sharing on the member, and then there would be some immediate, typically level 2, which would be the other network providers associated with their health plan, and then level 3, which would be out of network. So I know we've had discussions in the past about communication and some of the challenges, but again, if you want to talk about some of the potential barriers, would be the communication. You'd have to look at plan design. I think you'd want to look at travel and lodging, and then whether there's any potential political reaction to a facility being excluded by a state health plan. And I think that's just a real concern or a real thing that needs to be thought about as you go down this road. I think that's going to be the same thing if you do like Lodestar or any of some of the other things that we've talked about. There are going to be quote unquote winners and losers. Maybe that's not the right way to characterize, but there are going to be surgeons that would have less volume and potentially lose out if they're not meeting the quality metrics. So hopefully that, Jeff, answers your questions.
Oh, it does. And I have a brother who lives in Michigan that his orthopedic surgeon, he lives on the Lake Michigan coast, actively recommended that he go to a facility in Grand Rapids, which was a 2-hour drive. And I'm just thinking, that's nice that there is support for the concept of a facility with better outcomes and more sophisticated offerings. And I can't help but wonder how we do that in this state. But, I guess we just need to recognize that it could be a challenge and we'd have to figure a way to proactively address it.
How does it work? How does it work in the state of Washington with the Virginia Mason COE for, I think it might be King County or state of Washington, but they have a bundled payment arrangement or centers of excellence with Virginia Mason, which I thought was the only one in the state, but I could be wrong.
Yeah, well, United has taken an approach for what they call their spine and joint program to do a bundled approach. I think as we had some discussions earlier about will providers bite, a bundled payment obviously puts more risk on the providers, so they have to be more efficient and have to be comfortable with the care that they provide. So there are potentially fewer providers that would accept a bundled payment. And I think it does require a really well organized, not only the facility, but also their providers so that they work together collaboratively and they have kind of the bigger picture. I think also when we look at centers of excellence, we've had a lot of discussion about different initiatives that OEB and PEB have done in Oregon to improve quality and value-based payment. The whole previous hour on Lodestar was talking about value-based payment. So this certainly fits in as consistent with that approach as far as where you've indicated you want to go and what you've done in the past to work on this.
Ali, were you asking specifically about the King County Health Plan or the Washington State Health Plan and their benefit design and contracting with Virginia Mason?
Yeah, I was just wondering if there was anything on the eastern side of the state or if people over there were expected to travel there.
I can say anecdotally through other, the quality metrics we used were with Quantros, and from other work that I've done in Washington, I do know that there are some very highly rated facilities in the Eastern Washington area. very surprising too when you really start to dig down like that. But, so I think the answer to that is probably yes, but I don't know the specifics for those plans and who they're contracting.
Okay.
Yeah, very surprising when we went through and looked and said, where in the world is that? I haven't heard of those guys. They're doing really good. All right. So any other questions? Those are very good questions. Thank you for that one, Jeff. And
So what are our next steps here?
yeah, so we can skip. I think we've talked a lot about the OEBB specific considerations. So I think we can skip slide 11 and probably just go right on to slide 12. And that is really, we've kind of taken the implementation project plan and divided it up into 6 key phases. We can see phase 1, which is really take a deep dive look at your data. We have done that. We did that last year, and we started very broadly. As Lewis mentioned, we trimmed things down and really ended up focusing specifically on the musculoskeletal conditions. And phase 2, identifying the opportunity. We did spend a lot of time actually looking at quality and cost variation among the hospitals. So I think we've taken a look at what kind of opportunities we have in there, and again, kind of distilled ourselves down to those conditions. And that leaves us in phase 3, which is sort of taking a look at the approaches you can take to COEs that Lewis mentioned before, which were through the health plans, through carve-out vendors, or through direct contracting. And within that, taking a look at the vendors and what their offerings are and how they differ. Phase 4, that can be a little bit of a stickier area when you're really looking at and selecting and contracting with your vendor. I know sometimes we have some contracting challenges with the state plans here. And so we would need to, that's above my pay grade. But we would need to kind of go through, figure out how we best want to do that, and then start to work to incorporate that into the renewals for the next plan years. In addition to that, or as part of that, we would be working to identify which of the specific facilities and potentially even the providers and physicians within those facilities who would be included, taking a look at the benefit designs, including steerage, as well as travel benefits in there for implementation. And then phase 5 is your kind of getting your technical ducks in a row, getting your data feeds, coordination with the carriers, all that kind of stuff. And then phase 6, which I think is one of the most important, is your member communications. I think that's a very key one. You can put this program in place. There's all kinds of different ways you can approach steerage, from plan design and a carrot to all the way to penalties and sticks, through financial penalties. But at the end of the day, communication with the members is going to be very, very key to this. I have seen programs that were put in place that had almost no utilization due to a passive communication decision. So if we want it to be successful, we'll definitely need to make sure we reach out and communicate that. And finally, one that's probably not on here that maybe should be a little further down the road is going to be monitoring and reporting. We want to be able to take a look back at various points throughout the year, at the end of the plan year, and make sure that the COE vendor and implementation met our goals, around quality objectives, outcomes, engagement, and all those kind of things. So, we've got a little bit of timing on the side, just kind of sample timing. Jeff, you had a question?
Well, I should allow did anybody else in the group have a question? Okay, then I'll ask mine. Is there the option to set some standards with our current carriers, like Providence and Moda, and then measure their results in carrying out a system before going to a third party ostensibly to avoid fragmentation of services, so that we do an RFP or whatever once we've determined that they're not meeting our objectives.
Mm-hmm.
I may not have said that as well as I would like, but I'm wondering whether that's a step, especially if we're thinking in terms of Lodestar, which again is a repackaging, and I'm just wondering how much, where the cart is, where the horse is, where we're loading things up.
Mm-hmm.
And so prioritization, I guess, is partly the part and parcel to my question.
Yeah, I can sort of address that from the OEB and MODA perspective. When we queried MODA, they indicated a willingness to try and work and develop one or to partner. I don't think MODA would be adverse to partnering with an outside vendor for more immediate
Okay.
implementation. We've seen that in the implementation of the MODA 360 program, where they have been willing to work with additional vendors, and kind of leverage their experience and success on there. But right now, I would say they do not have anything in place, and I'm not sure how long it would take them to try and develop something. I think that could be a little bit of a challenge for them to do something by the next plan year cycle, potentially. I know, Louis, do you have any additional thoughts there?
No, I mean, when we went through the RFI, to your point, I think part of it is no one's really asked for it. So they haven't really felt the business need to go out and do it, but they did express a willingness to do it.
Okay.
The criteria and the analysis does require the data, but there's pretty good processes out there of how to do it. So it's not like MODA has to start from scratch, like what's the volume, et cetera. I mean, the thresholds that we mentioned. But I think the identifying them is probably going to be maybe easier than the contracting piece, especially if you're looking at bundled payments or warranties or those kind of things. So realistically, it probably would be in the 9+ month, maybe a year process for them. Once they got the word to go, once you all said, yes, we want to pursue this, then I think that's probably a reasonable time frame, which would make it difficult for them to meet your October 21 new plan year. But I would agree. I think if we can get them to do that and work with them pretty closely, that would be the ideal approach, because it's loaded in their system. You're not having to do a third-party vendor. And I think I would suggest that we exhaust that option before we go to a third-party vendor, because at that point, if MODA complains, which they may or may not, at least we tried to work with them. And if it just doesn't work out, and by no means am I saying they won't work with us, but I think they deserve an opportunity to see what they can develop.
Question for Sean. What is our going blank on names? I'll ask Sean because that name comes to mind. What has PEBB pursued along these lines, and if so, with Providence, where have you gotten?
Yeah, we've had a couple conversations about this. Ali, can you address that?
Yeah, I mean, PEBB really hasn't pursued any bundled payments or centers of excellence arrangements like OEB has, but have talked about doing something like that.
It's been a conversation, but we ended up having evolving into a different evolution of some providers.
Community care, yeah.
Community care, and then the whole hospital cap kind of derailed that. So it's been kind of a journey. But at one point, we were seriously talking about it. We didn't make it anywhere towards contracting or anything like that.
Mm-hmm.
Is that all right, Ali?
Yeah, it's really been the rural parts of the state, you know, that were, you know, obviously considerably higher cost. Joint replacement was an area that had looked at, and so yeah, as far as Providence and PEBB, it's a little bit different than OEB, where it's self-insured and they've kind of got the hospital system there, and you know, with the coordinated care model, there's you know, the hope that you could control some of the steerage there, but it's still an issue. You know, I do wonder about, you know, the VBP here, and you know, with COE and bundled payments. I'm not sure exactly where it lands on the LAN. I think it's around like 2C or something around that, but you know, the goal is to get to 3B and 70%. So long term, this wouldn't obviously get us there, but it would certainly save money and hopefully improve quality.
So is this something we should tackle as Innovation Workgroup together, or each board kind of choose their approach?
I think we can do the data work with the Innovation Workgroup, because you know, if you know, there was an opportunity to do an RFP jointly, you probably get a lot more bang for your buck. At least explore that option, maybe.
Yeah, it seems like if there's a center of excellence, there's a center of excellence, you know, and so I would rather do it together if we're going to do it. I don't know. That's my initial thought. It seems like you get more. Yeah, like Ali said. I mean, you might get more people willing to make a deal.
Yeah.
You know, the data you could combine in order to have that more fleshed out, and then, you know, we did get to the point of discussing it seriously enough to where, you know, we were thinking about our members, how they would react, and you know, kind of had a few conversations with labor, and you know, I think we felt like for specific conditions, specific things, you know, if you're going to have like a hip surgery, and it's part of the deal that we cover your travel costs and your lodging, as well as your you know, whoever you're bringing with you, because you need someone with you. We felt like most people would be okay with that, you know, because it's like you want your hip to, you know, like what is a 6-hour drive for a permanent new hip, you know, like at a Centers for Excellence, and it doesn't cost you anything. We're reimbursing you. It's just like annoying to drive six hours, you know. So I don't know. We felt that it was like it is possible. We think people would potentially go for it with the right framing, but we just, as I say, we ended up pursuing other things. But it makes sense to me. If we were to explore it further, we would do it together. It's my opinion.
So do we, I guess it's a question to Ali, in part it's rhetorical. Do we take this to our respective boards for them to approve us going together forward on a joint basis, or do we just go ahead and issue an RFP from the IWG and then report the findings back to the board?
RFI, you mean?
RFI, yeah.
Okay.
Yeah, it's a good
Process question.
My related process question is just, you know, first of all, can we do 2 RFIs? We just talked about an RFI.
Yep.
And then 2, so this fits, we feel, directly fits with the Lodestar thing, or would this be like a parallel but separate track, or just kind of revisiting that and clarifying?
Uh-huh.
Sean, this is James. I don't have fully refined thinking on that topic, but it seems to me that this could be more of a tactical and a short-term concept that could be built into your existing managed care plan arrangements. And the same ideas could be evolving in the Lodestar with the same or different categories of care, or the concepts of center of excellence could try to be infiltrated to the advocates. You know, if in a perfect world, you'd know the highest quality and best outcomes and most efficient providers for everything, and you just say, go there. But I guess I see this one in the current context as an easier fit.
Yeah, but not a mutually exclusive with the Lodestar either.
Yeah.
No, I think that, you know, we would want it bundled maybe in the Lodestar with the other good thinking that's supposed to be so integrated. And eventually this one would be pieced in with our current offerings. But I guess like we were talking about two sides of the coin, I guess I see this one as something you could be doing, like we've talked about, shorter term tactics. It's not super short, but it's shorter. And it would be in the current context, not in the future thing.
Yeah, I think that's a good point. This is something that you know, has a lot better shot of getting over the finish line quicker and being more impactful.
You know, and I would
Go ahead.
go ahead. Well, I was just going to say, we talked about the RFI sort of getting to see what the appetite of the providers were. Is this going to ultimately require legislation, you know, to get down the Lodestar road? You know, this could be on a much smaller scale an opportunity to just see how this goes as you're, say, working on Lodestar, and it might give you some early indicators about how the overall process would work, again, as it pertains to Lodestar.
Well, again, an RFI is pretty easy to do. We can definitely take this to the boards and, you know, kind of give them an update. It's really information gathering, but that certainly wouldn't be too difficult to do.
Okay. So you're saying we can go ahead with an RFI and then report back to our boards?
Yeah, I mean, I would see that as more information gathering than anything.
Okay.
You know. We can definitely give them an update during the IWG report at the next board meeting.
Okay. So who's going to do it? And do we need to have a budget first, or?
I don't think so. I mean, you know, like we said, it's really a matter of coming up with some questions, and you know, I guess it would take consultant time, but you know, it seems like this one would be pretty much more refined than the Lodestar, where you'd expect to get some pretty solid information back, and not nearly to the extent as the Lodestar. So.
And I'd add that we've already developed part of that RFI, you know, or at least maybe a little bit of a framework as we evaluated the current carrier capabilities as well. So maybe leverage some of that.
Okay. How are we staffing this? How would we staff this with consulting resources? One consultant, a blend? What?
I think, James, you can chime in, but I think we could probably, Willis Towers Watson's been spearheading this a little bit more, as Mercer's been spearheading the Lodestar, and I think we'd be happy to take on, some of that development work, and then work with James and team to finalize.
Yeah, I think that would work just fine. We have our history of those collaborative meetings, and you could lead the charge, and we could interpret and adapt the stuff to PEBB.
Okay. So this is really more of a consensus-driven group. So the only thing we vote on normally is the minutes. Do we need a vote? Or do we have consensus?
I mean, this is Sean. I'm supportive of that.
Okay,
Yeah,
Dana?
we're gathering information.
I'm supportive also.
JJ?
Yeah, me as well.
Okay. I guess we are in agreement. Okay. Well, that's how it's done in a civilized world. I'll leave it at that. March right up to the edge. Okay, is there anything else we need to talk about on this? If not, do we have any public comment?
No, sir.
Okay. Then I think we're able to adjourn the meeting, and so be it. Thank you, everybody.
Thanks,
Thank you
everybody.
so
All
much.
right, thanks all.
Thanks.